Well, Fawn, you sure can talk. That's all I can say. Really brought tears to my eyes, and now I have to say something. So let me say this, that to this group especially, I am so grateful and honored and humbled and energized by this award. When Christy called me, I was literally, I think I said this to you, bowled over, because this is, all these words are really a way of saying that this just means a lot to me personally, and also on the journey that I share with all of you in finding ways to improve healthcare and make the lives of our patients better. So thank you. Now, it's also tremendously meaningful to me that this award is in the name of Gail Warden. And I'm very sorry that he couldn't join us this evening. He's been an inspirational leader for many, many people, and no less for me. And in many ways, so I'll tell you a couple of them. I was a member of the Institute of Medicine committee that wrote To Err is Human and Crossing the Quality Chasm. We were all shocked at the time of what we found when we put these reports together. We knew we needed a lot of things, but we needed better information for consumers, providers, and payers about quality and safety. We built the idea of the National Quality Forum that came out of the Commission on Consumer Protection and Quality in the Healthcare Industry around the same time, that recommended a public-private, multi-stakeholder entity to set consensus standards for the nation for accountability measures. Who wants to do that, you know? Gail Warden wanted to do that, and he understood how important. It was wonky, it was technical, it was complex stuff, but it was essential because measurement produces evidence of quality. And as everyone knows, you can't make quality better if you don't know where you are and where your gaps are. But the measurement needs to be accurate. It needs to be believable and needs to be relevant to what patients really care about. So Gail took on the challenging task to become the founding chair, and he was a major force in creating this unwieldy and unlikely and essential organization in the particularly in the complexity of our American healthcare system. I'm sure those early days were not easy, and I give a lot of credit to the founding work also of Ken Kaiser and Janet Corrigan, working with Gail in creating that organization, which I had the privilege to lead until just recently. But also, we know multi-stakeholder work, and there's a lot more of it ahead of us, takes political skills, because stakeholders have many different perspectives, many different agendas, many different priorities. And so from Gail we learned, and this was just recently from a colleague of mine, in the hospital world as well as in the political world, when you asked Gail, what's the most important thing to be effective at running a hospital, he said very simply, it's good to have friends. You can imagine him saying that, right? So keep that in mind in the days and weeks and months ahead. Because I have another personal story about Gail, and that seems especially relevant right now. When I was in New York at Mount Sinai Medical Center, I worked with the Robert Wood Johnson Foundation to give birth to what is now the Center to Advance Palliative Care, which is led with amazing vigor and strength by Diane Meyer, who many of you know. In the intervening years, I was able to help create a new specialty of palliative medicine at the American Board of Internal Medicine, and to continue to focus on better care for patients and families who are facing the end of life. And then, in 2009, at the beginning of the healthcare reform efforts, the contentious debates surrounding the Affordable Care Act created the fear of death panels, which sent a chill through all the progress that we had made to raise this important and deeply personal issue to its rightful place in the healthcare world. Because of that fear, Kaiser Family Foundation, one point in that time, found that 30% of the Medicare beneficiaries in this country believed that death panels were part of the law. So it shows you the power of the media. And the developments in palliative care that we had all worked so hard to create were threatened. At that time, Diane and I were organizing a group of leaders to come together in Washington to raise this issue up, to talk about it, to dispel the fears and the myths. We needed a heavy hitter to send a strong message, and we invited Gail, and he didn't hesitate for a moment. He did the keynote for this major DC conference at a time when it was in the crosshairs of public debate. And he was clear, straight-talking, and courageous. I was so grateful, and will always be grateful, because now this issue is no longer hidden and controversial, but is understood to be a core component of high-quality, patient-centered care. So you asked me to just say a few little things about my career journey. There's this wonderful story in the program, and I'm really thankful for that. But if there's a single thread that I can think of throughout what I've done, it's been finding a way to understand, articulate, and embody humanism and respect for others in the complex, multicultural vortex of values that often appear to be in conflict in our society, but that need resolution. As a physician, understanding this complexity, I think, is the essence of professionalism. I think a lot about the soul of a doctor and what it means in the 21st century, not in a sentimental way. Because health and healthcare are valuable social goods, and because of that, physicians have two kinds of responsibility: to patients and to society. Seeking avenues to implement these core values led me to leave academia after a wonderful career there for a world of standard setting in the public interest, to the ABIM and to NQF. At ABIM, we took on overuse by engaging with consumers and choosing wisely. At NQF, we worked for recognition of the important role of social determinants in healthcare quality needs. Both of these efforts meant engaging the role of the provider as citizen, as a steward of society's resources, and as an advocate for community health. So, speaking of soul, several months ago, I got a call that was an opportunity to return to academia, but in a very different role. As the planning dean for the new Kaiser Permanente School of Medicine, I couldn't resist, because I've been frustrated, as many academic leaders are, about the ways in which the environments in which we teach medical students don't reflect the most high-performing, coordinated, efficient, patient-centered care systems in our country, many of which you folks do represent. One of these, of course, is Kaiser Permanente, and they decided to start their own medical school, embedded not in a university, but directly in an integrated, data-rich, team-based, population-driven health system. For me, to help this get started was really a once-in-a-lifetime opportunity. Students will not only get teaching about quality improvement science, they will see it all around them. They will not only get teaching about teamwork, they will see it all around them. It's an example of a different way of thinking about educating doctors. And it includes wellness, resilience, and change management as major parts of the curriculum, with diversity and inclusion as leading multicultural values. We're going to teach leadership as a core component of our curriculum. I think we need to be talking more to NCHL, as well as many of you. So in closing, it would be disingenuous not to mention the outcome of last week's presidential election and the tremendous uncertainty that it's cast into our world of healthcare. that world was already grappling with enormous change. Much, much progress has been made towards what we call the triple aim: healthy communities, better health care, and affordability. We may find that that particular language falls out of favor, but the goals, access to care for everyone when it's needed, quality and safety that patients can trust, personalized care, population-based health strategies, and reducing waste all must continue, must remain our goals. Think about it. Access, quality and safety, personalized care, healthy communities, reducing waste. Whatever legislative and policy changes are ahead of us, the leaders in this room and others like you, like us, must not let these important values become the death panels of our era. We need to reach out, engage, influence, innovate, and sustain these values and the directions that they lead us in. These values are not partisan and should not be political. Voices from the private sector, especially now, are vitally important and will be heard. So like Gail Warden speaking up for palliative care when it was most needed, what we say and what we do now matters more than ever. This is a time for leadership, if there ever was one. Thank you so much.